Lateral epicondylitis is a known indication for shockwave therapy. There are nice guidelines in support of this. 2015, Thiel and Gerdersmeyer stated that the treatment of lateral epicondylitis is known to show conflicting results. As a shockwave educator, I have been receiving quite a few inquiries from new shockwave therapists saying that they're not getting the results they've expected with lateral epicondylitis in particular. And also there are some educators on webinars who have stated that their results aren't quite as good as with, say, some lower limb tendinopathies. And I think this is actually more a case of suboptimal patient selection. So what we're going to go through here is some clinical reasoning and go to some methodical manual muscle testing and palpation to understand how to select patients optimally for shockwave therapy who come in with lateral elbow pain. Now, we all know that with lateral epicondylitis, the main pain will be around this region here, lateral elbow, just on the distal humerus. And this area can be largely from the radial collateral ligament or the common extensor origin or the radial head. If you've defined that the patient's problems are from one of these three structures, they are actually perfect indications for shockwave therapy and you're likely to get good results. However, here in Sheffield in my clinic, we have a high volume of rock climbers. I treat more elbow problems than most people. There are other factors to consider that mimic this classic presentation of CEO lateral epicondylitis. One of them is a brachialis driven pathology. The other one is a Pec Minor driven. And the other one, which with subsections, is cervical, pretty much C5 right down to T10. So we're going to go through methodical testing of how you're going to isolate and sift out these other brachialis, the Pec Minor, and the cervicothoracic syndromes, so that if you decide that none of those are active and your problem is driven by elbow only, locally at that lateral epicondylitis region, you know you're likely to get good results. The two main tools I'm going to be using are methodical manual muscle testing and palpation. Good old basics for the therapist. So we're going to go on to a screening demonstration of manual muscle testing right now, how I go through it with every patient. I start from the hand, then to the elbow, and I'll add some shoulder influences. So I'm going to have my subject sitting here right now. And this is what I do with all patients. So first of all, I will say squeeze my fingers tight as you can. Squeeze, tight as you can, and just relax. Even though I treat some of the strongest climbers in the country, if you offer them only 3 fingers, they cannot hurt you. Offer them 4, they'll break your fingers. Only give them 3 fingers, and you'll be able to then feel what is actually going on with their grip, and just relax there now. So the first actual single manual muscle test I call opponent's polysis. So hold your thumb to your little finger, hold that together as strong as you can and hold. Good. That's either going to be strong or weak. Note it, okay? Pop the palm down, fingers out straight. Now I'm going to test intrinsics. I'm going to test intrinsics between 3 and 4 first of all, and hold. And you know that's an ulnar nerve muscle. Hold between 4 and 5. Hold. If either of those are weak or if both are weak, you know you might be looking for an ulnar nerve pathology. So hold between 2 and 3. Hold. Good. Hold between 1 and 2 and hold. And obviously, if that's weak or if that's weak, 1 and 2 and 2 and 3, you may be looking at a median nerve. But we don't know yet. We're just information gathering at this point. So now we go on to testing flexors. So bring that hand down, pull all the fingers back towards yourself and pull so you're getting a good idea. Now isolate each finger. Start with the index, pull that towards you. Pull the middle finger towards you. Good. Pull that ring finger back towards you, and the little finger, pull that towards you. And that might give you information that will support what you found with the intrinsic muscles. Obviously, we'll be comparing both sides. For the purpose of this video, we're doing only the one side. Bend the wrist back. So from that position, pull the wrist back, hold. Now you need to test the extensors of the index because, as you know, anatomically, ECRL inserts to the base of that metacarpal and ECRB inserts to the base of the middle finger metacarpal. Hold. And with climbers, we add a couple of supplementary tests. This is for climbers only, for specific grip. If you hyperextend through the MCPs, pads to the palm, and pull the pad into your palm, keep that extended, get that right back, that's it. Make sure they're hyperextended, get that one right back, so we're onto that ring finger, hyperextension, and that little finger, hold that right in. That's fantastic. There are other specific climbers tests that we'll introduce pretty much only on our master classes. So elbows into your sides, we need to go into pronation now. Okay, so rotate that forearm down, hold that forearm down. Don't let me twist it. That's it, hold. Rotate out, don't let me twist it, and hold. Good. From this position, bicep, push up. Good. For tricep, I always turn the hand into this position, push straight down. Good. And then we're going to do brachialis. So if you flip the camera now, and bring that arm back to yourself, and pull that in there. And that's a really important strength test. Now, holding that view there, to palpate brachialis, bring the arm back out, just relax the arm. To palpate brachialis, you can see the position I'm in there, and that's the bicep tendon. If it's a brachialis-driven pathology, you will feel tension in through this area here, just proximal to the elbow crease, lateral to the bicep tendon. That should be totally pain-free. It really doesn't matter what the patient does for a living, a builder, joiner, gardener, landscaper, whatever. That should be pain-free. Even a marathon swimmer should be totally pain-free there. But if that's sensitive to touch, fixing this and understanding this is more important than understanding what's happening at the CEO, because the CEO will always be sensitive to palpate. So you palpate there, occasionally be medial, but this is the one you need to palpate all of the time. So if your condition is brachialis driven, there'll be two definite signs. The brachialis will be sensitive to touch on that palpation, and that brachialis manual muscle test, which we demonstrated, will be weak. There will be variable signs with the strength test in the other forearm and hand muscles. And you might be asking, well, why is it variable? And that's a really good question, and it took us a lot of thinking to try to come up with an answer to this. And it's down to our old friend of central sensitization, which is something that tries to throw a spanner into our clinical reasoning in all conditions. When it comes down to the anatomy, you have the radial nerve passing between the brachialis and the brachioradialis, as you can see on this ultrasound scan. With that, when brachialis is tight, it is very rarely painful, so there's usually a massive length of chronicity that we don't realise. Through that, through this central sensitization phenomenon, you can see through this radiopedia clip that the radial nerve has roots from C5 to T1, basically every contributor to the brachial plexus. So that means through the dorsal root ganglion and the dorsal horn, it's decreasing the firing threshold potentially to the ulnar nerve and the median nerve as well. So in the hand, you might have an ulnar nerve bias weakness, or you might have a median nerve. You'll never have both, but it could be either. So that's a really interesting point. and we're going to be discussing the actual physical treatment of the Brachialis syndrome as an appendix to this video. So as we mentioned before, if the problem is brachialis driven, you'll satisfy two criteria. It'll be sensitive to palpation, proximal to the elbow crease, lateral to the bicep tendon, and you'll have weakness or pain or both on that resisted brachialis manual muscle test. If it only satisfies the one criteria of sensitive to palpation, it is not brachialis syndrome. And to repeat, the reason you are identifying this, because if it's a brachialis or a pec or a spinal driven issue, you're not going to get those results with shockwave on the CEO, right on where that lateral elbow pain may well be presenting. We need to identify these syndromes to treat them, to treat what the patient is actually physically presenting with. So the next step is looking at Pec Minor. Now there's a fantastic article by Panther et al. Thoracic Outlet Syndrome and Review that's referenced just here. And you'll see from their picture of the Pec Minor. The Pec Minor arises from the coracoid process, just here, and inserts right onto the rib cage further down. And the importance, you can see this neurovascular bundle, it's the whole of the brachial plexus just coming down through under there, and that's the importance. If it was just a tight muscle here on its own, it would be of probably very little significance. But because you've got the neurovascular bundle, you can get all sorts of mayhem and referral coming from a tight muscle here. And climbers in particular, and people who are sitting in a poor posture at their desks holding a mouse, will tighten up through here regularly. So if I palpate through this area that you see on the picture from Panther et al., I can feel a load of tension just in there. So I'm going to say to this patient, that's likely to be quite sensitive. How does that feel there?
It's quite tight, yeah.
Now, if it's a positive Pec Minor syndrome, and if it's something that requires treating, most of the time, I'd say 95% of the time, within 30 seconds or so of eliciting a response like this, the patient's likely to feel some sort of radiation into the forearm, whether it be heaviness, tingling into the fingers, or something vague. Can you feel anything going into the forearm?
Feels quite dull.
Dull. Okay, that's great. So that's satisfying that criteria. And what's going to be more significant, if your patient's got a one-sided problem, if it's different to the other side. And if I go straight to the same area on the left, that's just not painful at all. So if this was a patient here, is only my subject for the video to explain the overall process, but if he did turn up with a lateral epicondylitis or even a medial elbow problem, golfer's elbow, I would be looking to eliminate this prior to actually treating the local area. And again, we treat lots of climbers who present with Pec Minor issues. Even the worst case I've seen, it took 9 to 10 weeks of a patient being on a home program. A little bit of treatment helps a lot. A lot of treatment doesn't help much more. The exercise program, which we'll discuss further in master classes, but we'll list it on the appendix at the end here, will actually help this condition quite a lot. So you just angle that down so you can get the pec in again. That's it. And so treatment one, what I would do first of all, I would massage that at the first presentation for about 7 minutes. And then I would have the patient sit up and we will review the strength tests. If there was weakness in the strength tests, I would expect there to be a change. And so to satisfy the criteria of a pec-driven problem, we would have tenderness to palpate, we'll have referral of some symptoms through the forearm, but with this there will be definite weakness in the hand, and it will be either the ulnar or median nerve biased signs there in your manual muscle tests. Again, because we you can't tell. If you go back to that picture from Panther, it could be median or ulnar nerve. You can't tell from up here, so it'd be a variable weakness presentation. But unlike with brachialis, where there's sometimes no weakness in the hand, with Pec Minor, my experience is that there is always some identifiable inefficiency or weakness in those intrinsics or in those flexors in particular. So they're my go-to tests. So if we're unsure that it's this brachialis or it's Pec, then we're going to palpate into the spine. So by this point, you've performed some manual muscle tests to understand what's going on efficiency-wise through the arm, through the hand, forearm, elbow, and you've tested brachialis strength test. You've palpated brachialis, you've palpated Pec Minor, you've implicated or eliminated those. The next part to understand is this potential spinal contribution. So if I have our subject case down here, the region of interest really is the whole area from C5 down to L2, because you've got down at L2 you've got the lumbar aponeurosis from which the lat dorsi arises from. So you can actually, in some odd cases, occasionally we've had to treat sort of as far down there. But if we sort of you need to understand what your own skill set is with lumbar palpation, thoracic palpation, cervical palpation. It's beyond the scope of this video to teach it, but in clinic I would palpate through the whole area, and quite often I'll choose to not treat it, but if there's something that may be significant, I'll note it, so that then I've got a plan to go to if the effect of my treatment seems to be suboptimal. So I'll palpate through the spine, I'll have a feel around the scapula, obviously I'll have the patient's shirt off, so I'll be palpating right on the skin, infraspinatus, teres minor, supraspinatus, upper traps. I'll be understanding what's going on throughout here. And once I've understood what's going on there, the next thing, the last thing, is to understand what's happening at that lateral epicondyle. And for that I'll palpate the area, and I'll often perform an ultrasound scan, and that's what I'm going to do now. So to complete my objective assessment for a lateral epicondylitis presentation, I will offer an ultrasound scan. I will follow the ESSR guidelines and really look at the whole series of shots, starting with the anterior elbow, ensuring that I can see the structures clearly. So I can see that distal humerus nicely there, seeing that medial epicondyle, and then making sure we see the radial head and long axis, going up to the humerus, and taking in, ensuring that you get that all-important coronoid fossa shot. And that's a really important one that often practitioners skip over, and that's going to give an insight is maybe there's some arthritic or joint pathology, and if the coronoid fossa is likely to show some inflammation or distension of the fat bed, if that's the case, then we go for the classic CEO last of all. And realistically, you're looking to differentiate the structures there, the parts of the common extensor origin and the radial collateral ligament. And as this case is a model rather than an actual patient, we're seeing that it looks pretty much pristine. If we were to treat with shockwave, the actual treatment is the simplest part. I would be using my focused shockwave. I would have the patient lying supine. I would probably perform 2,000 to 3,000 pulses depending on what pathology was found there. And then I would reassess my findings, whatever might have been weak or painful, or perform a functional test. Now, we haven't described functional tests, but for example, if my patient said that he was going to circuit training and he had pain on press-ups, after a treatment of focused shockwave, it would be a good idea to actually perform things where he might actually, tests that might be actually really meaningful to him in real life, like his press-up or some other exercise that he performs regularly.